Welcome, everyone. It's the top of the hour. We'll invite you all to today's GlomCon. Today is our Clinical Trials Conference series, which is a joint venture between GlomCon and NephCure. Our topic today is driving innovation for patients with FSGS and IgA. So before I introduce our speaker and panelists, I'd like to tell you a little bit about NephCure, where their mission is to accelerate research and effective treatments for rare forms of nephrotic syndrome and provide education and support to improve the lives of those affected by those with protein spilling kidney disease. And one important part of NephCure and their mission is this Kidney Health Gateway, which is a resource for physicians, patients, family members to find clinical trials that are available for specific diseases and in the area, and this is the search tool for that. So to our talk today we have Dr. Bruce Hendry, the European lead nephrologist at Travere Therapeutics, an emeritus professor of medicine at King London College. He also is a clinical and academic nephrologist trained in physiology, biophysics, and medicine. He was the former head of renal science laboratory at King's College in London and the former president of the UK Renal Association. After his talk today, we'll have a panel discussion. Our panelists today are Dr. Brad Rovin, professor of nephrology and director of the Division of Nephrology at the Ohio State University, Wexner Medical School. And he's the medical director of Clinical Research Management Institute at Ohio State. Dr. Donald Kohan is professor emeritus in the Division of Nephrology and Hypertension at the University of Utah. And Dr. Kenneth Lieberman is the chief of pediatric nephrology at Joseph Cinzari Children's Hospital and Hackensack University Medical Center. So with that, I will stop sharing. We'll turn it over to Bruce for the presentation.
So thank you very much indeed for the invitation to Travere Therapeutics to talk about our development program for sparsentan. And it's an honor for me to be presenting on behalf of the company. This is a pretty high-level group of people, so I hope to talk briefly to give a chance for our expert discussants to take your questions and discuss this whole field. The invitation to us is very welcome. The first issue about this is balance. I've been invited to talk about sparsentan and our program, but of course a balanced talk about innovation in FSGS and IgA would include a number of other programs. So I'm going to accept that I will be unbalanced. I'll talk about sparsentan in some detail, but at the end of the talk I will come back to the context and try to put this into the context of the other programs which are taking place to restore a bit of balance to the occasion. Let me first indicate a caveat, which is that sparsentan is an investigational product, not a licensed agent, and therefore everything I say about its potential for patients is ineffectively to be said with the additional phrase, if approved. I won't keep saying that, but that's what I mean, and I'm going to talk about this program for educational purposes, not to induce anybody to use the agent pre-approval. So first, a few things about Travere. We are a biopharmaceutical company specialized in identifying, developing, and delivering life-changing therapies to people living with rare disease. Our pipeline is led by sparsentan, which is a dual endothelin angiotensin receptor antagonist, and it's in trial for the treatment of primary and genetic FSGS and IgA nephropathy. We also have a program on TVT-058 or pegtibatinase for classical homocystinuria, currently in phase 1/2 study. We also have earlier innovative collaborations on a range of genetic and metabolic diseases. Travere has commercial products in the United States, which are indicated top right. Our headquarters are in San Diego, California, and we also have an office in Dublin, in Ireland. The focus of our company is very strongly the patient, and our chief executive, Eric Dubé, has created a very clear culture of patient focus. And I show in this slide a picture of 4 individuals with FSGS and IgAN who gave up their time to talk to us about how their diseases affect them And this has been very inspirational for the whole company. We are aware of the unmet need, and we are aware that there is a great deal of work to do. Very briefly for this audience, the burden of FSGS and IgA nephropathy. FSGS first, a heavy proteinuria disorder. I'm talking here about primary and genetic FSGS. The disease is characterized by nephrotic syndrome and nephrotic range proteinuria. Current standard of care includes high-dose steroids, and despite current standard of care, only a minority of patients attain and retain a complete remission of proteinuria. So these patients are looking at a significant chance of progressing to end-stage kidney failure within 5 to 10 years. IgA nephropathy is a disease with a wide spectrum of severity. There are very mild cases, but data available at biopsy is able to stratify these patients, indicating a large group, perhaps as many as 40 or 50%, who are at significant risk of end-stage kidney disease within 10 years. In both of these diseases, I think there is clearly unmet need for improved therapies. And in the case of FSGS, to some extent, IgA nephropathy, a burden of therapy due to the effect of steroids. So there is a great deal to do to improve the outcome for these patients and to develop new therapies in order to do so. Primary FSGS is a podocytopathy. This slide is a very brief cartoon about what can happen to podocytes when they're injured. And the point of this slide today is to say that all of these negative processes, all of these effects on podocytes, once initial injury has taken place, can be and are driven by a range of cytokines. Prominent among those are endothelin-1 and angiotensin-2. And there is a wealth of preclinical, cellular, and some clinical evidence that angiotensin-2 and endothelin-1 act in tandem in order to damage podocytes, including calcium abnormality, cytoskeletal rearrangement, foot process damage, detachment, cell death, and all of the things that lead to podocyte loss and progressive renal failure. So a very strong logic to inhibiting those pathways. Angiotensin 2 via the AT1 receptor, we do so already. ET1 via the ETA receptor is not yet available therapeutically. And this was the logic behind the DUET study, which I shall talk to you later, our phase 2 study of sparsentan in FSGS. There is a range of information available to show that proteinuria maps to outcome. For FSGS, a wealth of registry level data, some trial level data indicating that sustained proteinuria and a failure to respond to therapy maps to very poor renal outcomes. And the initial target of the sparsentan program has been to demonstrate high antiproteinuric activity in order to justify the optimism about renal protection for the agent. Here is a schemata showing the pathophysiology of IgA nephropathy. You'll be familiar with the MEST-C scoring system. I show this slide to point out that the processes which underlie M, E, S, T, and C are cellular and molecular events driven by the milieu of signaling molecules in the glomerulus, and prominent again in those molecules are endothelin-1 and angiotensin-2. And so each of these effects that you're looking at the bottom, proliferation of cells, inflammatory cell activation and recruitment, the inflammatory response, the process of generating and laying down matrix, are all driven by endothelin-1 and angiotensin-2. And they are driven in that way in the context of the disease, both in preclinical and in some clinical data. So again, a very strong logic to inhibiting not just angiotensin-2, but also endothelin-1 in the context of IgA nephropathy. And that's the basis on which the PROTECT study has been designed, which is designed to trial sparsentan in IgA nephropathy. As in FSGS, there is an abundant evidence in IgA nephropathy for a link between proteinuria and its level and renal outcome. In the case of IgA nephropathy, the trial level data is actually very strong, that where therapeutics or interventions have reduced proteinuria, they have also prolonged renal survival. And that is again the basis for the initial objective of sparsentan and the program of work on sparsentan to demonstrate extremely effective anti-proteinuric potential in the context of high-risk IgA nephropathy patients. Now, here are the latest KDIGO guidelines, or at least a summary of some of the key features for IgA nephropathy. And you will see that beyond the initial supportive care, including RAS inhibition, the next step is to consider enrollment in a clinical trial. I think that's good advice, but it also does tell us that we're very uncertain about what to do with the IgA patients who don't respond to initial therapy. There is a nuanced approach to steroids, as you can see and will know. Individual risk stratification is advised, but in the end, the advice is to use steroids if you think it can be done safely for patients who are not controlled. I don't think that's a very good place for us to be. My vision for the future would be this slide would not use systemic steroids, but there would be a range of other therapeutics that we have an algorithm-based approach to. And I'm very optimistic over the next few years that we will get to that point. So here is a very simple schema showing that endothelin-1 and angiotensin-2 are potent cytokines which are dually acting and they cause damage in numerous compartments: vascular damage, glomerular damage, tumor interstitial damage. And they do so through pathways which are interacting in a positive manner. For example, angiotensin-2 increases the gene expression of endothelin. For example, endothelin-1 potentiates angiotensin-2 pathways, and so on. So there's a great rationale for giving antagonism of these agents in the context of renal disease. However, on the right-hand side, we have to be very careful. Endothelin-1 inhibits sodium reabsorption, and a total blockade of the ET1 system will cause sodium retention and edema. Whilst most of that is an ETB receptor-mediated process, that's not the entire story. And even ETA selective agents have been noted at higher doses in type 2 diabetics to cause fluid retention. And therefore, any strategy that is going to target the ETA receptor needs to demonstrate safety, or at least a manageable safety, in the context of the disease and the patients to be targeted. And that's the challenge that sparsentan has to address, because no amount of efficacy is worthwhile if we have unacceptable safety. So one of the features of the studies of sparsentan is a very careful approach to fluid status and to examining whether there is a safe way to use such an agent in the context of FSGS and IgAN, and the monitoring of fluid status and the careful selection of patients and the titration of drug dosing are all part of that safety process. So here is another cartoon, the glomerulus, multiple cells. There is a great deal of crosstalk occurring in glomerular cells in the context of disease progression. The ETA receptor is expressed on many of these cells. Endothelin-1 is made by a number of these cells. And in the context of progressive damage, there are a number of processes which are dependent on the ET1 ETA receptor pathway, and those processes tend to be working in tandem with the angiotensin-1 receptor mediated damaging processes. So I've listed them here, but we've got podocytes and endothelial cells are engaged in an ET1 based crosstalk. We have podocyte foot process effacement, as well as architectural changes which are driven by endothelin-1. Mesangial cells in IgA nephropathy are proliferative, and part of the signaling for that is ET1 via the ETA receptors. And the development of the inflammatory environment is driven and further exacerbated by overexpression of ET1. So a whole range of rationale for using or attempting to block the ET1 pathway via the ETA receptor in the context of progressive glomerular damage. Now, in terms of IgA nephropathy, we proceeded directly with sparsentan to a phase 3 study. And the phase 2 study that's missing is indicated here. It's not a study of sparsentan, it's a study of cilexentan, which is a selective ETA receptor antagonist. And in this work, which I think is really interesting, the group in Scotland, led by Dawn, demonstrated that out with diabetes in proteinuric CKD, randomization of patients who were fully controlled on RAS inhibition to this ETA receptor antagonist, cilexentan, was able to cause a 30% reduction in proteinuria, as shown in the orange columns. And this was clearly distinct from placebo on the left and the blood pressure control nifedipine on the right. And most of these patients had IgA nephropathy. So although this is a very small study, as a proof of principle, it demonstrated, I think, for the first time that out with type 2 diabetes, targeting the ETA receptor, in addition to the targeting of the RAS system, could have benefit in further reducing proteinuria. So what is sparsentan? It is a dual angiotensin and endothelin receptor antagonist. And we are very optimistic about this molecule because it appears to be able to inhibit both these receptors in a way that is, at least in our early stages, looks to have a tolerable and favorable safety profile. Sparsentan has got high selectivity, both for the ETA and AT1 receptor versus ETB and AT2 respectively, of over 500-fold. It's a daily tablet, and in the preclinical environment, there is plenty of evidence that it is capable of preventing glomerulosclerosis and reducing proteinuria in models both of FSGS and of IgAN. So the rationale for using sparsentan in FSGS and IgA is indicated here. Many of the things on this slide I've already indicated to you, but you're able to block two independent pathways of damage with a single molecule, with a single molecular species, rather, of sparsentan. And the main caveat that requires careful observation is the possibility that the ETA receptor blockade could cause edema, and that needs to be very carefully observed. So here is the clinical trial program for sparsentan listed in full. The DUET study phase 2 is complete in its double-blind period, and I'll describe the key results of that in a moment. Sparsentan targeting FSGS, primary and genetic. The Duplex study is active, fully recruited. It is again studying in phase 3 sparsentan in primary and genetic FSGS in both adults and children. And the interim 36-week proteinuria data for this study is available. I'll mention that in a moment. The PROTECT study is a phase 3 study of sparsentan in IgA nephropathy. This study is fully enrolled, remains active. The study also reported its 36-week proteinuria data interim analysis recently, and I will show that to you in a few moments. Those are the three studies, DUET, Duplex, and PROTECT, in which sparsentan is being put head-to-head against active control irbesartan at 300 milligrams. And as I will show you shortly, in each case, it appears to demonstrate superiority. The last two studies there are single-arm studies, but nevertheless, I think very important. The EPIC study is a pediatric study looking at the safety, efficacy, and pharmacokinetics of sparsentan in pediatric patients from age 1 to 17. And this is a study in selective proteinuric diseases which I will list for you in a moment. And then finally, the Spartan study is another single-arm study, and this is an attempt to study sparsentan, the safety and efficacy in incident IgA nephropathy. That is, patients who have been diagnosed with IgA nephropathy, who have not seen RAS inhibition. In other words, the first time these patients receive any AT1 receptor inhibition will be the A of DIARA of sparsentan. The study is being led by John Barrett in Leicester and is at the moment entirely based in the UK. The Duet study demonstrated in its 8-week randomized period that the proteinuria reduction by sparsentan was superior to irbesartan. The data is shown there, 45 versus 18.5% reduction. The Duet study demonstrated that sparsentan was well tolerated and adverse events leading to drug discontinuation were rare. Importantly, there was a non-significant excess of edema in the Duet study in the sparsentan arm. These were almost all mild and moderate cases. They responded to standard of care with increase in diuretic use, and they did not lead to study drug withdrawal. So this test of safety with respect to fluid overload, I think, was broadly passed by the Duet study, although the number of patients, 73 in total, is not sufficient to be compelling, but it was sufficient for us to feel that this should proceed into a phase 3 study in Duplex. This is the Duplex study, phase 3 double-blind study targeting the question as to whether sparsentan is safe and efficacious in primary and genetic FSGS in individuals from age 8 upwards. The patients are randomized after washout to titrate up to 800 milligrams of sparsentan or 300 milligrams of irbesartan. The whole study lasts for just over 2 years. The interim efficacy endpoint is the 36-week achievement of a proteinuria target, the proteinuria being reduced to below 1.5 gram per gram PCR with a 40% reduction, which we're terming an FSGS partial remission endpoint, or FPRE, at week 36. And then the primary endpoint of the study is going to be looking at the rate of change of GFR over the whole study, and individual slopes of GFR over time will also be examined over 1 and 2 years. This is the interim endpoint of the Duplex study, which was positive. That is, the number of patients achieving FPRE as a percentage was 42% in the sparsentan arm, 26% in the irbesartan arm. This was highly significant. So sparsentan is superior to irbesartan in controlling proteinuria in the context of the patients in the Duplex study. The safety and tolerability information was encouraging. Sparsentan was generally well tolerated, and the safety profile was comparable comparing sparsentan and irbesartan. Now, I would really like to give you a tabulated patient-level set of information about the safety of the data, but with this trial being ongoing and to maintain integrity of the study, we have been limited in what we can say in detail about it. Top-line data is expected in the first half of 2023, which will include the eGFR 2-year endpoints. This is the PROTECT study of sparsentan in IgA nephropathy. Study is again a double-blind active control study. In this case, patients with IgA nephropathy are recruited. They have to have biopsy-proven IgA, proteinuria above 1 gram per day. Crescentic IgA is excluded. And I should have said that both in this study and in all the sparsentan studies, a history of heart failure is an exclusion for entry to the study. So in the PROTECT study, sparsentan is titrated up to a 400 milligram dose versus 300 milligram irbesartan. There's an interim efficacy endpoint at 36 weeks on proteinuria, and then confirmatory endpoints over 2 years of rate of GFR change over the 1 and 2 year periods. The other thing I should add is that both this and the Duplex study have an open label extension in which all patients will be offered sparsentan. And to add to that again very briefly, in those periods of time, patients will be permitted to use, if prescribed, SGLT2 inhibitors. The interim data from PROTECT is shown here. The sparsentan-treated patients had a 49.8% reduction of proteinuria versus a 15% reduction in irbesartan, a clear and significant superiority. The safety data was similar. Sparsentan was generally well tolerated, and there were no new safety signals in this study beyond what has been reported for Duet and for Duplex. And this study will complete in the second half of 2023. Now, briefly, these two other single-arm studies, the EPIC study, evaluating proteinuria in kids. This study is important in two respects. One is it extends the age at which we are going to gain experience of sparsentan safety and efficacy down to 1, so that patients between 1 and 17 are recruitable to this study. And the second thing is that there's been a widening of the entry criteria. So patients in population 1 can have FSGS proven by biopsy or genetics or minimal change disease. And in population 2, they can have biopsy proven IgA or IgA vasculitis or Alport syndrome defined genetically. So we're beginning to look at the possibility of the efficacy and safety of sparsentan in a slightly wider cohort than were used in Duplex and PROTECT. The study has begun. I believe patients have begun to be recruited, and it will run for some years. And Spartan, very exciting study because so much information should be generated by this. The Spartan study will recruit patients at incidence who have not received RAS blockade. They have to have biopsy-proven IgA nephropathy, and they will then be given the option of treatment with sparsentan, titrating up, if tolerated, to 400 milligrams. And the key endpoints will be the proteinuria data and the eGFR change over 1 and 2 years. But importantly, this study will allow us to consent for a second biopsy targeting week 24. There will be bioimpedance information about total body water with regular follow-up, and there will be also multiple follow-up with renal and cardiac MRI, looking both at hemodynamic and fibrotic indices. In addition, there's the option for biomarkers to be studied in plasma, serum, urine, and in the biopsy to confirm, for example, target engagement with sparsentan in this group of patients. So, single-arm study, complementary to the PROTECT study, but I think could be biologically very interesting in its results. So, to summarize, I won't read all this out, but we do have a common understanding, I think, that FSGS and IgA nephropathy are proteinuric diseases with currently unmet need in the standard of care. We have a wealth of evidence that endothelin 1 and angiotensin 2 pathways are involved in the amplification and generation of renal injury in these diseases. And I've shown you something about sparsentan as a first-in-class agent, a dual endothelin angiotensin receptor antagonist, which is under investigation in these diseases. And the preliminary data suggests that sparsentan is a potent antiproteinuric agent, and the preliminary safety data suggests that safety issues with this agent are manageable, but more information is required. I point out the 3 features of the studies which are internally consistent with each other. One is that in each case, when head-to-head with irbesartan, sparsentan has proved superior and by some margin, particularly in the PROTECT study where there is a 3-fold improvement in proteinuria compared to irbesartan. Secondly, the magnitude of the effect of sparsentan is impressive, where we have the continuous variable data, as in both PROTECT and DUET. Sparsentan is when started, is going on to generate 45 to 50% reduction in proteinuria, which I think is a significant efficacy. And thirdly, the 3 studies all indicate tolerability and what I think is emerging as a manageable safety profile. Let me finish by just putting this in context. As I said at the beginning, that this is not the only innovation in FSGS and IgAN. There are other studies taking place. So I would highlight the fact that there are studies looking at targeting B cells, studies targeting complement pathways, targeting the ion channel function, and there is also the emerging evidence that SGLT2 inhibition is therapeutic in CKD in general, and indeed in certain primary GN. So that's actually a very exciting position to be, because we are looking at the potential for a number of new agents. We don't know which will be successful overall, but a number of new agents for treatment of these diseases. And I think we're going to move to a phase, rather than asking, does agent X work better than standard of care? We're going to be asking, does agent X work well with agent Y? And what combinations of these new therapies should we be using in each individual patient? So I think it's a very exciting time. And I think sparsentan is well placed to be a part of the toolkit in future, if approved. I will stop there, and I'll stop sharing perhaps and hand back to Dia.
Thank you, Bruce. I think we have a lot to talk about, and lots of questions that have come up and talking points. I think we'll kind of start. There's some questions and talk on physiology, kind of pathophysiology and mechanism of action. We move towards the edema component and how that fits in with everything, and kind of go from there. And then some questions on the biopsy side of things too. As far as the kind of mechanism of action, it kind of went over nicely where the things act on the different cells. One question is we talked about 2 disease processes that primarily affect different cells when looked at kind of from a biopsy perspective. So maybe, Don, I think, has had a nice paper several years ago, which talked about the endothelin receptors and the various parts along the nephron and glomerulus. Maybe we can just touch a little bit on where those receptors act, and then how those kind of correlate to IgA versus, which is more a mesangial injury, versus FSGS, which is a podocyte injury, and how that all relates, so we can better understand the targeting of this and working in both diseases.
Yeah, thanks, Dia. It's a tough question. We have a lot of preclinical data, and we make a lot of assumptions from the clinical data. So anything I say is, largely based on the preclinical stuff. But we know that, every cell type in the kidney has endothelin receptors, and virtually every cell type makes endothelin. And there's obviously a lot of crosstalk going on, data showing crosstalk between podocytes and endothelium, probably between mesangial cells, endothelium, and podocytes as well. So I think it's really hard to talk about, the endothelin system in a particular cell type in isolation. That said, mesangial cells are known to respond to endothelin via the ETA receptor, and this causes mesangial cell contraction, proliferation, extracellular matrix production, and a very detailed signaling regulatory system has been worked out at least in cultured cells. Same thing for podocytes. There's a lot of data showing that, for example, podocyte-specific knockout of the endothelin receptors, both the A and B, is really quite protective in particularly a model of diabetic kidney disease. And again, in podocytes, endothelin via the ETA stimulates the proliferative, the fibrotic, and extracellular matrix as well. So I'll kind of stop there. I could talk forever about it, take any questions.
And Brad, we'll let you continue to comment.
So I'm going to direct this at Don and everybody, but I know Don has really devoted his career to looking at endothelin. But I looked at an interesting paper from Charlie Alper's lab, Don, where they had done an experimental model of diabetes, and they suggest that with an endothelin receptor antagonist, not only is the podocyte protected, but they actually got an increase in podocyte numbers, possibly coming from the parietal epithelial cell. To me, regardless of the disease, whether it's a primary podocytopathy or IgA, down the road, podocyte damage occurs in proteinuria kidney diseases. And as we lose podocytes over time, the stuff by Roger Wiggins, you get glomerulosclerosis and that you hit some point of no return. So what do you think about those data? Is it possible that this could evolve into a mechanism to help us regenerate the GBM and the podocyte?
Yeah, thanks, Brad. I haven't seen anything specifically on endothelin's effects on parietal epithelial cells. I mean, obviously familiar with the work about how they can regenerate the podocyte, but nothing about endothelin specifically. There was, and again, unfortunately, it's only in diabetes, an interesting study by Ariella Bignini a number of years ago, where she looked at giving an ETA blocker, an ACE inhibitor, or both, and measured the degree of glomerular sclerosis, and actually saw with the combination therapy, that is the ACE inhibitor and the endothelin antagonist, regression of diabetic kidney disease, and in fact, normalization of the histology. That's a pretty unusual finding, but it does suggest that maybe what you're saying is a possibility.
This is Ken Lieberman. I just wanted to also point out a paper that I had come across that I found particularly interesting from the nephrology lab at Sinai a couple of years ago in KI, about the role of endothelin in the crosstalk between podocytes and endothelial cells, and that by blocking the, in a mouse model of, two mouse models of FSGS in this case, that blocking the endothelin receptor, the A receptor, one was able to limit the degradation of the endothelial part of the triplex filtering membrane, which suggests yet another way in which the interrupting that endothelin pathway could be beneficial in this case in FSGS.
Right. I think there was an Ebifor's paper. I'm not sure if that's the same one. And
That's correct. That's the one
Yeah.
I'm talking about. Yeah,
that was in KI in 2019.
correct.
And yeah, so blocking the endothelin system improved endothelial histology, and also very interestingly, improved in that model the endothelial glycocalyx, which has also been seen with endothelin blockade in other kidney disease models.
I would defer to you, of course, or others who might know, but I had not come across another mechanism for actually that degree of improvement on the endothelial side. We have a number of the agents that we already have and that are in the pipeline seem to be ameliorating podocytopathy, but I had not seen many interventions that affect the other side of the GBM.
It's interesting because when you look at endothelin, as with most things in nephrology and probably other specialties, we sort of start out with what that primary action of that molecule is, which may have been vasoconstriction when it was discovered. but it seems like it does lots and lots of things. I sort of wonder how we're going to come to a conclusion as to what its predominant mechanism of action is, because I hope we'll discuss a little bit, Don and others, of the effects of endothelin on inflammation. And the reason I say that is because we have so many new drugs in the pipeline. And I agree totally with what Bruce said at the end of his talk, which is we're not going to ask which single drug is going to be useful for a patient. We're going to combine drugs, almost certainly. And I think that the idea of, is an endothelin antagonist primarily working on the podocyte, helping the podocyte cytoskeleton, which I believe it does, and then we would add in an inflammatory disease like IgA nephropathy, for example, we would then add a drug more directed towards inflammation. Or is the converse, is endothelin acting more at the inflammation level and we would want something working better at the podocyte? I don't know how to sort all that out, given all the different effects that have been shown.
I think, Brad, maybe the problem and also the good side of this is that you can't package endothelin neatly. It's increased urinary endothelin, which derives entirely from the kidney, is increased in every experimental model of kidney disease.
Right.
And so it's coming from the tubules in those circumstances, and where just tubules are being affected. It's coming from glomeruli, and its actions are multiple, anti-inflammatory, et cetera, et cetera. So I don't think we're going to be able to package it neatly. And I think this is an important point, because I've sat in on conferences where so-called thought leaders have said, well, blocking endothelin basically targets the vasculature. And it's much, much more complicated than that.
And I think that goes to Dr. Mayer's point in the comments about, considering the terminal pathway of glomerular sclerosis among all kind of glomerular diseases. Should we be, looking at sparsentan across many of them as opposed to just specific disease processes? And then Dr. Glassick had made a comment about the ENDAPA-CKD. There was a 26% reduction in proteinuria, translated to 75% relative risk reduction in kidney failure. But the question about utility of using decline in proteinuria as a surrogate for kidney failure endpoints in IgA. Do you guys have any comments on that, and how we should we be looking at different biomarkers of fibrosis instead of all on proteinuria?
Can I'd like to make a statement on that. He is smiling because I know that she knows me and she knows I have a statement on everything. But I'm going to try and do this in an evidence-based fashion. Proteinuria is not the end-all be-all of glomerular disease. And I'm just going to bring this up in the context of a disease that's near and dear to me, which is lupus nephritis. One of the things we've seen, particularly with the BLISS-LN trial, is that there was not necessarily a profound difference in the proteinuric endpoint between the patients on belimumab and the patients receiving placebo plus background care. But what we did see was a very important difference, in my opinion, in GFR preservation in the belimumab group, as well as the number of patients reaching a sustained 30 or 40% decline in eGFR. So the idea that we focus everything in our trials on proteinuria has been sort of a convenient surrogate. But I think what we're seeing now in these trials, like Dick mentioned, and the lupus trials, and almost certainly in the IgA trials, where proteinuria might be an early endpoint, but the FDA is now requiring a GFR endpoint, is that we move away from this necessarily a proteinuria issue and look at what's really happening to kidney function. Because in the end, we want to preserve kidney function. If I have a patient that has a gram of proteinuria, but their GFR is preserved and they never go on dialysis, I'm okay with the gram of proteinuria. So I'll start that conversation off.
Yeah, I'd just like to make a comment. As much as it pains me to agree with Brad, I'm forced to under this occasion. And it's, I think it's relevant that while proteinuria per se, is not obviously the end all and be all, there was a paper that was just in press for Jason, where the response to atrasentan during sonar enrichment period. So you recall there was a 6-week enrichment period where everybody got atrasentan. The UACR response to that was an incredibly strong predictor of the hard renal outcomes at the end of the 2.2-year period of treatment. So that doesn't negate anything Brad says, but I think that's interesting data directly about atrasentan and CKD.
Right, thank you. I think since we're getting closer to the hour mark, let's move on a little and talk about side effects and the edema. And I think that the fluid retention that was seen kind of in the sonar trial, and then is that going to be similar in non-diabetics, or what are you looking at, Bruce, in that regard maybe, and then we can talk a little bit about the mechanism of that side effect.
Yeah, I think it's important to recognize that different populations of patients may have different sensitivity to that potential problem. So I would encourage us not to read across directly from the early studies in type 2 diabetes, or indeed the SONAR study, into the sparsentan program. I think it needs to be judged on its own merits. So if you take, for example, DAPA-CKD, it's quite clear that the IgA patients in that study are 10 years younger than the diabetics. And I think that considerations like that are going to influence the rate of edema and problems with an ETA receptor antagonist.
And then if the edema is related to fluid retention, I think the next question that's come up, and you also addressed and put this out to the group, the use of SGLT2 inhibitors, right? So there's some, with the sodium handling, the potential diuretic effect. Do we see that, you said you will be looking at that maybe in an extension study, and Dr. Glassick brought up that point. Will there be either post-market comparison or RCT? Maybe there's, some mechanism of action that dually together would alleviate some of those side effect profiles.
Yeah, I'd agree with that totally. I mean, as you know, this small study from SONAR where patients did get both atrasentan and the SGLT2 inhibitor gives an encouraging data set suggesting that that was good for fluid retention. We need to see the data emerge as we look at combination therapies in the future. But in theoretical terms, the combination of sparsentan plus an SGLT2 inhibitor looks to be promising, but we need more information.
Yeah, there is going to be a trial. It's called Zenith, coming out of AstraZeneca, where they're going to be given a highly selective ETA antagonist called zibotentan, together with an SGLT2 inhibitor or alone, and comparing the effect on proteinuria and fluid retention. It's going to be about 660 patients. It has 2 arms, and they're projecting results in probably a couple of years.
And then one other question along those lines from just trial design and endpoints, and because of the edema, potential side effect of the edema, are you looking at PROs, or are they just clinical endpoints in the ends of some of these trials?
Yeah, there's a full set of patient-related outcome measures being collected in these studies. So we will have that information along with the usual clinical follow-up, which includes body weight and assessment for edema at every visit. So I think we should get the clear picture as the trials emerge.
All right, and then one of the big questions that's come up is about biopsy, and Dr. Glassick had asked a question, I think for you, Bruce, about time point of biopsy for IgA in relation to enrollment in the study. And then we can talk more, I think, with the group. And I know Brad will have some comments on biopsies and serial biopsies or biopsies at the end of trials to help us kind of understand better what's happening.
Yeah, in these studies, the biopsy didn't have to be immediately prior to study entry. There could be a historical biopsy. I think there may be a limit of years, but I'm sorry, I can't recall the exact limit. But there is the possibility.
It was like 5 years, Bruce. 5 to 7 years.
Brad knows more than I do. So the biopsies could be semi-historical, and I think that's important because, for example, the MEST-C score is probably not telling you a great deal about what happens 2 years later in terms of detailed pathophysiology.
So I think that's really, there's two ways of looking at it. The fact that the biopsies could be so long ago, with the possibility of progression, suggests that if the drug proves to be effective, maybe it's working on fibrosis in general, which would be a good thing. However, we can't pull that out because we don't have the current biopsy. And so I will advocate, I will suggest that in the PROTECT study, there will be a sufficient number, albeit a smaller number, of incident biopsies. For example, anyone enrolled at my site in PROTECT had a biopsy coming in, so we would know what's going on. We personally don't think it's necessarily the right thing to do to enroll a patient in a study where maybe all they have is glomerulosclerosis and interstitial fibrosis and there's really no hope. And I realize that's mitigated to some extent by the GFR criteria coming in, I get that. But I would do a post hoc analysis of the PROTECT study, looking particularly at the patients in whom we had incident biopsies to see how that correlated with, the endpoint, to see if there were particular issues with the MEST score. And I'd also like to use in those particular patients the calculation of the IgA prognosis score that Sean Barber has developed. I think, that way we can start to understand in whom these drugs are going to be useful. And maybe it is generally useful for everyone. Maybe this is acting on, the final common pathway of podocyte loss and interstitial fibrosis, and it doesn't really matter what you're coming in with. But, in IgA in particular, where there may be an inflammatory component, maybe this is more relevant. Maybe this works really well in E1 and not as important in E0. I'm making that up, of course, I don't know. So the question of repeat biopsies is something, we've been tackling in lupus, and really does have relevance, I think, for other glomerular diseases, because we don't want to do bunches and bunches of biopsies on people all in a row. But until we can start to correlate what we see in the urine as a potential surrogate or biomarker, what we see in the serum, with what we see on the histology, we won't be able to get away from histology being the gold standard. So, I think at this point in the evolution of our understanding of glomerular diseases, especially now that not just for FSGS and IgA, but in all glomerular diseases, there's sort of a renaissance in therapeutics. We really do need to start to understand what we can use non-invasively to reflect truly what's going on in the kidney. And that means biting the bullet. And this era of patients is probably going to need repeat biopsies.
Yeah, I fully agree with all that. And I would add that the Spartan study could begin to contribute to this with the protocol for a second biopsy. I was not, having worked with Travere a lot, I was not aware of that particular study. So that looks like a very exciting study, frankly. And albeit single arm, I think we will get a lot of information from that study. And I'm going to volunteer us to participate right away. Yeah, I should add that it's being led by the University of Leicester. They
Yeah,
support
well,
Travere, but they are the leaders in the
a
study.
little bit alike on this biopsy issue.
And Kenneth, can you comment on in children what kind of timeline from biopsy that we see from study enrollment and things like that? Is it any different than kind of what we're seeing in adults where we have these very older, maybe historical biopsies? Kenneth, you gotta unmute.
Ben, you're on mute.
Sorry. Yeah. Certainly not in Duet and Duplex that had significant pediatric involvement, right? They went down to age 8. And there was similar delays, similar timeframes, I should say, in terms of biopsy. And I guess, as all of you know, we have had pediatrics, that is, pediatric nephrology has had particular issues with repeated biopsies at time of study enrollment or follow-up biopsies. And I'm sure you all know the issues. So I don't see the peds world is going to be able to contribute very much to the biopsy issue. I would point out, though, that EPIC, the follow-up with EPIC being put together, which is just so exciting for us. It goes down to age 1, where there are not a lot of new agents that that are available for us down to that young age. Partially that came out of the fact that we did a post hoc analysis on the Duet data, which was presented at PEDS meetings, that showed for the pediatric cohort within Duet, there was the same sort of proteinuria reduction and reaching the FSGS response endpoint as in the adults. And that was very encouraging. And Travere went ahead and put together EPIC. And the other thing, I think I'm the token pediatrician, but the other thing that Travere very kindly did for us is they actually created a pediatric sparsentan compounding, right? So that's what's being used in EPIC. In the peds world, we're excited to do EPIC to treat down to age 1, but that's also the first trial that's going to use this new child-friendly sparsentan compound. It's also going to be the first sparsentan trial which will include minimal change disease and Alport syndrome. So, you know, both extremely important to us. And so it'll be a small trial, but has the capacity to contribute some really important new information in other entities that haven't been studied before with this agent.
Brad, you have your hand raised.
Well, I was just as Ken was talking, I was looking at the chat, and there were 2 interesting comments. One suggesting that podocytes in the urine might be an interesting biomarker, and the other was about developing imaging as an endpoint. And I like both of these thoughts. The stuff out of Michigan from Wiggins suggests that you can look at podocytes. I don't know how clinically applicable that could be, albeit I suspect we could find a surrogate for that. And that there is a lot of activity in the imaging world looking at functional MRI and other imaging modalities to try and understand truly what's going on in the kidney without having to do an invasive biopsy. But of course, those studies are being done with the biopsy and the imaging done together at this point.
Yes, and I think to Dr. Brushfield's comment, I think we'd had a session with the European Renal Association on kind of the functional imaging in the past. So things early in development, but definitely something to look forward to, for hopefully in the horizon. All right, so we're almost to the end. I'll let, if anyone has a question, please feel free to unmute and ask if we missed anything in the chat. All right. Well, I think we're at the end of the hour, so we'll wrap up. I thank everyone for joining. Thank you, Bruce, for sharing all the information about ongoing trials through Travere, and then to Brad, Ken, and Don for your contributions to this very excellent discussion. I think there's a lot more we can discuss in the future again, and hopefully have new therapies soon for our patients. And I thank all the audience for their participation in bringing a lot of these talking points to the table. So with that, we'll end, and thank you guys all for spending part of your Sunday with us, and have a good week. Bye, guys.
Great. Bye, guys. Thanks very much. Good to talk to you.